Hey guys, Alex with RASA. Laparoscopic skill of the day, we're going to talk about local injection and trocar insertion. This is usually a fun one with our bread and butter here. So let's get into it. So you're going to need a syringe filled with water, hypodermic needle, skin kit, your knife blade and handle, laparoscopic viewing box with foam attached, and your laparoscopic trocar. All of these things should be in there. Scope of practice warning. Always confirm that local infiltration and trocar sites preparation are within your professional scope of practice and permitted under your facility's policies. Delegation rules vary by state, institution, and credentialing body. So when in doubt, ask your supervising surgeon or check with your regulatory board before performing these. Local injection pros. So you want to mark the trocar sites first. Plan port placement with your surgeon before injecting. This prevents wasting local sites that may shift once landmarks are confirmed. You always want to aspirate before each pass, especially important near abdominal wall vessels, inferior epigastrics. Infiltrate in layers. Start with a skin wheel, then infiltrate subcutaneous tissue, then down to the fascia peritoneum if your surgeon directs you to do so, then inject on withdrawal to spread evenly. Fan the needle. At the skin and fascia, fan slightly to cover the anticipated incision length and trocar diameter. Volume does matter, so about 3 to 5 mLs per port site is usually adequate. More may be needed for 10 to 12 millimeter ports or in obese patients. Make sure to check with your surgeon. And again, anticipate those larger ports. Place extra local at the fascia level for 10 to 12 millimeter trocar sites to reduce that post-op pain. Time the onset. Inject early so local has 2 to 3 minutes to take effect before trocar entry. Extend to closure. Re-infiltrate fascia or sub-Q layers before skin closure if you want to maximize post-op pain control. Check with your surgeon as well as your anesthesia provider. So here's just an example here. I'm coming in at a nice 45-degree angle. Make sure I'm in there. I'm going to aspirate and then go ahead and press in the local. That's just one of the examples I have here. And also guys, make sure you don't have any air in your syringe. That's really naughty. You don't want to do that. And here's another angle. I'm just kind of restarting this for you guys here again. So coming in here with that angle, making sure I'm in. Quick little aspiration. You can do it with one hand if you like. Just make sure you're checking. If you have blood, don't do it. And then once I'm good, I'm going to go ahead and push forward and inject local. Okay, so let's talk about trocar insertion pros. So patient port and positioning is everything. True 90-degree table rotation, arms tucked, pneumoperitoneum at recommended pressure, improves insertional angle, and decrease risk. Now, elevate the abdominal wall, whether with your non-dominant hand or towel clips. Lifting the fascia gives you more distance from viscera. 2-pop technique is you should feel 2 distinct resistances, the fascia then peritoneum. If you don't, take a second, pause, and reassess the situation before going again, and especially reassess with your surgeon. Angle of entry, so your initial trocar, especially the umbilical, is usually at a 90-degree in thin patients. Slightly caudal in obese patients to avoid the great vessels. Control the trocar. Hold it like a dart, but advance with your palm over the guard, not fingertips, so you can stop instantly. Always check intra-abdominal placement. Look for insufflation gas flow, intra-abdominal pressure drop, and direct visualization with the scope before using the port. And respect old scars. Adhesions live there. Choose an alternate port or open Hassan technique if prior midline laparotomy was there. So here we're same thing again. I'm going to do a little injection there, and actually I saw there I got a little air bubble. I'm going to pull out and make sure I flush the local, make sure there's nothing but fluid in my syringe. Coming again, I'm injecting, and see I'm kind of making that wheel, and it's kind of perfusing through the tissue there. And I'm going to take my knife. I don't need to make some huge incision here, just usually going to take a very small incision depending on the size of your port that you're inserting. Usually this is with an 11 blade. And then I'm going to take that trocar there, and you're going to see my palm is over and my fingers are kind of guiding with a twist and push to kind of dissect through there. You'll feel those 2 pops like I mentioned. Once you're through, go ahead and pull the guard out and you're good to go. Thanks guys.